Good evening, everyone. Am I audible and visible to everyone? Today we are embarking on a very interesting topic, yet a very overwhelming topic, reflexes and sensory development in autism. Well, the three big words in this title, reflexes, sensory, and autism, are in itself big, huge deals in itself. There are hundreds of books defining each of them separately. A lot of uh, child neurologists, uh, researchers, practitioners, therapists, pediatricians in the world of handling children and children with developmental issues. It recent years has shown a deeper research and understanding of how child development happens right in utero, from when the conception happens to the time of the entire pregnancy, the whole process of delivery, and the early months. So all of them separately are so very important to understand what happens when a child's development is not on track. It is so enigmatic, in fact, to understand that how this whole miraculous process happens when, right from the conception, uh, various stages of gestation, when the mother feels the movement of the babies, what kind of neural growth is happening in the baby, and how it automatically after the birth turns into the child trying to control neck, then learning to roll, sit, walk, and all other higher gross and cognitive social skills. Now, what happens through early development? Uh, as one of the therapists myself, I think I have been introduced. So yeah, not adding there any between. As a therapist now working for 20 years, going through many courses, reading a lot of books, now having handled probably thousands of kids, something comes to you as intrigue, especially when you see children on the autism spectrum. I have been working in the NICUs also, so I see a lot of these preterm babies through their first year of life. And with some of the excellent pediatricians that I'm associated with, have been able to now identify babies as young as 4 months and being sent to me to see Richa, the eye contact hasn't yet developed, and so let's do some early intervention. And so we have had those fascinating stages where we've been just 4 months, not yet tracking, not yet looking at the toy, or maybe looking at the toy and not looking at the face. So we really need to do some early intervention. And so learning about reflexes as a student, also we were very intrigued by reflexes and how development happened, but that time it was more so with cerebral palsy and other neuromuscular disorders. But lately, in the last couple of years, it has been more of these neurobehavioral disorders that we have been also linking the role of reflexes. Now, to define reflexes, I'll just pull through my presentation, which is a brief anchor to um, help us in understanding. Yeah, just give me a moment. All right. I hope you all can see my presentation. So now, as I said, I have three huge words, in fact, for development in itself in this topic. And given the few minutes that I have to talk today and share some information with all the esteemed guests hearing me this evening. Uh, Now, reflex, the definition reflex is an automatic, unlearned, and unvolitional response to a stimulus that a human body may react to. And it is always the same. Reflexes are protective in nature. We still, as adults, have some reflexes. If I may, eat something which is not my, it is not edible. There is a gag reflex which will make me puke it out, and it's protective in nature because it protects my gastrointestinal system from any external influence. Now, similarly, all babies, when they are born with many reflexes in their body. They don't have the volition. If a baby is born, he or she cannot yet want to reach out to mama's face, and they cannot do anything purposefully. So they are a combination of a lot of reflexes which makes them feed. So there is a sucking reflex, there is a rooting reflex, there is a reflex that protects from any potential danger. So for example, if there is a loud sound and the child will go, this is the moro reflex. If there is a sudden, if you're holding the baby and there is a sudden jerk, so the baby's body will suddenly go like this, and that's the moro reflex, the purpose of which is to give the baby protection. The purpose of rooting and sucking is for the baby to be able to feed from the mother. So it's so natural that when a full term baby is born, the moment the baby is put on the mother's breast, the baby would start sucking. And so there is an automatic reflex, which means you don't have to tell the baby to start moving the mouth because you're being fed, but it's natural. So a baby is born with a lot of these we call them primitive reflexes. And all my sensory development, now senses are my vision, my hearing. I want my mouth, so I want to be fed, so I have the sucking reflex, which helps me in feeding and later in my speech. The sucking, rooting reflexes, my palmar reflex. So you all know, when we hold the baby's hand when they're born, up to 3 months, they will just tighten and they hold your finger, and it's the grasp reflex, which eventually is meant for their good hand functions and fine motor skills. So initially, in the initial 0 to 4 months, most of these reflexes start inhibiting. They start getting converted to more purposeful movements. So we all know, after 4 or 5 months, when the child has the deliberate ability to start rolling and to start reaching out for something, they are now, the primitive reflexes are gone, and now they get converted to more postural reactions, more purposeful movements. So the link between primitive reflexes and sensory development is very important in general for a good motor planning, a good mapping for the child to explore sensory motor world. In autism, these reflexes do not go sometimes. They persist. They stay in the child's body and cause difficulty in processing the right volitional sensory information, causing difficulty in acquiring effective motor and sensory skills. Now, this is the difference when the most important part all parents should know, and fellow therapists who are hearing me today, is that we are talking about reflexes which are retained, which should have integrated in the body, because it's like, I'll be showing you. So a lot of our reflexes are start developing in the uterus itself. So if you would see the moro reflex, the fear paralysis, they start developing as early as about 8 weeks in gestation. And most of them have to integrate by 6 to 9 months in the human body, one or two persisting till 1 year, like the plantar reflex and others. But when I say the word integrated, I mean they are just getting converted to now more purposeful movements. So here you see, as soon as the primitive reflexes are now going down, definitive motor actions are happening. And now these definitive motor actions are happening through appropriate sensory development also. So the child now wants to touch the mother's face. The child now wants to taste different things in the mouth. He or she is hearing various sounds and processing them. And these, to hear a certain sound, if I'm playing a rattle here and I turn my head to look at this sound, this is my sensory motor development. And now, if my ATNR reflex, which is the reflex with the head movement, is persisting, and in a normal ATNR reflex, the head turns to one side, the side at which the hand goes, the other one goes behind. Now, if this reflex is still aberrant or not integrated, my eye-hand coordination doesn't develop well, and I'm showing some varied and some not very refined movement quality. So this is what we also observe in a lot of children under 1 year of age. When you're suspecting something, they do not look like developing very normally. They may be doing their gross things okay. They may have started to sit, but they're not reaching out for objects. The moment they turn their head, they fall down. And so we are, looking at something which is going off track. So I come to this point where I say when the primitive reflexes go down, the postural reactions and purposeful movement only happens then. And the brain processes about now if I about the location, the potential danger that I may be, falling. I'm on the edge of the bed, I'm rolling as a baby. Now I reach the edge of the bed, I feel the border of the bed on my back, and that touch of the corner of the bed sends a signal to my brain that, oh, I might fall, and I have to just turn back to the bed so I don't fall. And sometimes when that reflexes or that volition is not that strong, we see and we hear parents saying the child has learned to roll, and it has fallen from the bed a couple of times. So we now know that rolling is happening because ATNR has integrated, and now the effective rolling, but more refined when the child learns, now I'm at the edge of the bed and I'm not supposed to fall. I need to now hold myself up, or I put my legs first down so I can touch the floor and then get down smoothly. These are all mapping from the sensory motor responses and feedback that the skin, the joints, the muscles are now sending to the brain. And I have a goal directed adaptive behavior. And that's the definition of sensory integration also, which Ayers, we all have learned from her books, from the courses that we've done. Now, this very specific theory of sensory integration and reflex is now coming to the picture, I hope. And you all now can understand that the crux of these theories are so interlinked. In children with autism, somewhere something is, so primitive reflexes are not retained, are retained. Their quality may be different. Babinski in his description of reflex not only talks about the correct response, but also the quality of response. So the quality of movement is different in our young children with autism, and therefore their sensory development has already started to show some variation, some specificities. कोई बहुत ज़्यादा हो रही है, कोई बहुत, something is very less in nature. So there are many studies linking reflex and sensory and autism. So one of them shows that children with retained reflexes have sensory discrepancies, specifically in vestibular disorders, more like dyspraxia and postural disorders. And we all know that our children with autism have some sort of postural, gait, movement related issues. And now, if as therapists and parents we understand where it's coming from, all our treatment patterns till now that we also, which are which we try, the sensory integration or other reflex integration therapy protocols, are all overlapping. Let me take you through through that. But this is one chart showing a lot of these reflexes which you may not really have to know by as parents maybe, but yes, few of them to understand that yes, a lot of these reflexes, and if you would go to the last column of this, are all also issues we look at in autism when we talk about decreased eye-hand coordination, poor spatial awareness, toe walking, hypotonia, um, poor coordination, messy eater, um, difficulty feeding. So all these are also a complex outcome of retained reflexes as shown in this slide. I was also talking about when I said, if you look at this picture from the inside up and the outside in, when the sensory processing is happening and all these primitive reflexes are controlled by our lower centers of the brain, the brainstem. Now, when they start integrating, so they send a signal. So the cortical functions, the anterior part of our brain, the frontal cortex, develops appropriate thoughts, develops imagination, beliefs, adaptive behavior, which are also our challenges when we look at autism per se. So there is a link when the internal mechanisms haven't. So the bottom up approach is not, there is a blockage there. The top down approach, when the cognition has to develop, and specifically with social adaptive behaviors, imagination, beliefs, thoughts, there is a difficulty there. So now when I was just talking about how the principles are same. Higher sensory integration talks about prone extension and supine flexion as the structured observational analysis when we look at children to understand their sensory processes. And say, for example, there is a Landau reflex, which also talks about posture, motor development, and if not integrated, memory issues, attention issues, concentration problems. And if I show you how they are exactly the same. The position of a Landau reflex, which is typical for, in the right side picture, if you say typical for a 5-month-old baby, when it gets excited using this prone extension, but it integrates by the time they're 9-10 months old. And prone extension is also a structured, skilled observation in sensory integration himself in this prone extension position. So the link between these postures, the link between how development is happening early also has led to the development of our therapy protocols, how we now use them to help our children on the spectrum. So it is applicable to other developmental areas also, but today we are talking about autism. So I'll just take a little case study that I worked with. So this is an 11-year-old boy with autism whom I was working with, and the mother's complaint was still with his toilet training, not trying new foods, and not accepting changes in routine. On my analysis, on a little workup, we identified 3 reflexes which I felt were mostly, I could see in the child's postures, I could see in his mannerisms, I could see in the way he was scanning the environment. And we selected spinal parese, Elant, Moro, and fear paralysis reflex and worked for about a month or maybe just 6 weeks. And on the right side is just her response to me that after so many years of efforts, the child is now tolerant. So a lot of these reflexes, specifically the spinal gland, spinal parese, also have their correlation with gastrointestinal issues, feeding issues. Moro and fear paralysis are most commonly known to be affected in children with autism, causing a lot of these anxious behaviors, and which we, from the sensory perspective, when we look at it, we also talk about their challenges with hypersensitivity to sound, hypersensitivity to touch. So they're kind of anxious, this Moro response, if something might happen. So there is, now if I understand that, and if I work on integration of Moro reflex in one of our children, then I might reduce the hypersensitivities as well, and which we have very categorically seen in a lot of our children whom we have worked with these protocols. So a lot of study when I scanned to see which are the most common affected reflexes in ASD. Moro reflex, number 1, ATNR, STNR, TLR. 4 reflexes, if you would see, are usually retained in our children with autism spectrum, on the autism spectrum disorder, and if worked upon, can show results. There is a slide, and a lot of research talks about the retained reflexes, but lesser outcome on the therapies has been documented enough. So there are studies, but few. But in our practice, we have been utilizing what we best know of the various reflex integration therapies, and we've seen good outcomes in our children. So now I'm just showing you one picture of the normal ATNR reflex. So you would see this in a 4-month-old child, perhaps, who would, turn his head one side, and the hand should go this. If the head goes like this, the hand should reach out. And this is a normal ATNR position of this gets integrated by 4, 5, 6 months, and then the child is able to roll. The child is able to reach out to different things if they want. While they're reaching out, they can even move their head. Now, if this persists in the body of this child, there will be difficulty with self-feeding, visual tracking, eye-hand coordination, midline crossing, and eventually maybe handwriting, blackboard copying, use tight grip, and challenges with translating ideas into written words, which again we see in our children. Mororeflex, we just spoke about it. It is connected to all sensory systems. So whatever, if the kind of sound, smells, tastes, light, movement through space, even internal feelings, we sometimes wonder what happened suddenly to a child, and the children are in this zone. There could have been an interoceptive feeling that activated the mororeflex, and so it is very strongly entwined with sensory processing. I'm just putting down a few pointers here, which is 7 or more of these questions should indicate that the mororeflex is present in the child. So, for example, distress on being touched, irritated by socks, distress on loud noises, emotionally having difficulty after separation, extreme emotional reactions, bad tantrums, aggressive behaviors like biting, hitting, pinching, difficulty regulating activity levels in the day, hearing but not listening, not processing, getting disturbed by bright light, showing disturbed sleep patterns, does not see the need to communicate or interact with others, and has emotional outbursts. So somewhere when I'm also talking about these, we all understand that these are also the things that we see with our children on the autism spectrum, and therefore working on the mororeflex. And these would also, sometimes I may see an isolated child with just an anxiety disorder being referred. And then once you see, and you see the reactions, they're like, sometimes you're working with the child and you just, you flip something to show, and the child does this, which as if, you were, but this is not, sometimes, somebody must have hit him. So no, it may not be right. It is also a natural reaction where his moro is already there. We all still have those startle reactions sometimes. For example, if I'm standing and suddenly a door is barged on, I may just do slightly this, which is not moro to tell you, but this is our startle reaction, which is a lifelong protective reaction in us. So now you know that there are, so similarly, we have tests for all individual reflexes to see, and then if they persist in our children, there will be sensory processing challenges. They choose one sense as their, priority sense to explore the world with, because they don't want to be overwhelmed with this multitude of senses. And so their nervous system selects isolated sensory channels through which they try to learn and perceive the world. And in our sensory language, we say, he's a visual learner, he's an auditory learner. So this is what is perhaps happening through the growing years when we have been, understanding the child. So all these sensory issues that we talk about, uneven surface, gravitational insecurity, not being able to walk on the sand, not being able to bear the sound of a vacuum or a mixie. These are all, we put them under sensory processing disorders, which also, as I just explained, could be part of the retained mororeflex. And since it happens so much with the child, so every day, every hour, probably some of them are going through it, so their flight and fright reactions are high, and which has increased cortisol, like increased in their bodies, and it exhausts their adrenals, causing also maybe food sensitivities, allergies, even asthma and other health issues. So what we are trying to say is we have to understand that there is an internal mechanism, and this very line by one of a very senior therapist, Karen Pryor, says if a child is on a constant alert mechanism, is on a constant running around, he won't be able to learn. So a child who's running away from a person who's running away from a lion, you can't tell the child to read. We have to understand that we need to calm down the system. We need to accept, and we talk about accepting a lot of sensory issues in our children now. So we need to bring about the hyper and the heightened reflexive responses. How we do it, very importantly, we all the time we say, we understand now what's happening, how is it treated. Of course, you need to be taking help from a therapist who understands these theories and can help you uh, integrate. But some simple things that probably I could say, for example, if you think maybe my child has the Moro, or my child has the retained ATNR, for a retained ATNR, a simple exercise like telling the child to crawl on all fours, and simultaneously, if the child is able to read, for example, so showing some word cards at the side and asking the child to rotate head alternatively left and right and read the different cards that you're showing, or placing a book on the back of the child and asking the child to do a kind of push up, so that, and then looking around with the neck. So when I'm isolating the neck movement and making the hand go either in the crawling up and down, a lot of our rhythmic movement training patterns, the dance movement therapy, brain gym, Crispiani methods, all are somewhere based on these movement based training methods, which are indirectly, directly also helping in reflex integration. For example, if I make the child do this exercise, okay, when I test also, I say, can you do this? So it's an easy way to understand whether this movement is affected and therefore the reflex could be retained. Another way to maybe help a child integrate Moro is, it's a very popular exercise by the name of starfish position. So we make the child lie down with all four limbs outstretched, and then I probably give a little bolster or a teddy bear to hug on the baby's chest, the child's chest, and I ask them to hug by bringing all four limbs towards the body, hug the teddy, hug the bear, and then outstretch it. So I may be doing it one of these exercises, which has really shown excellent results in calming down a lot of our children. They can be done actively, passively, converted to a game, maybe play-based reflex integration, dance-based reflex integration. There are various methodologies being used. What works for which child is very unique and individualized, and their interests to be integrated with that. So yeah, I think I kind of sum up here uh, to 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 take few questions if there are now, and if there questions that I would take up and be more happily answering those queries. And I hope what gist I have given just now has kind of opened up a few of our thought processes to understand what may be going on with our children and how we can make them more and more functional, joyfully more and more functional, by understanding the insides of them rather than only looking at their superficial behaviors. So I'll just can are there any questions which I might take up? I guess there are no questions. Was I that clear? And mm, I was expecting a lot of questions because I thought this is, uh, yes, we may end today's session, and any questions later on, perhaps we'll take up. I would like to thank Autism Connect for inviting me and letting me share some of my knowledge. And I hope it helps and helps a lot of our parents, fellow team members, therapists, and have a very good evening, everyone.